Hello, my name is Joshua Murray. Today I'm excited to present my machine learning final project, where I built a predictive model to detect heart disease using clinical patient data. This project is important to me personally because heart disease has impacted my family, and early diagnosis can truly save lives. Moving on to the problem and data set, the data set I used is called heart.csv, and it includes 919 patient records and 12 features, covering both numerical and categorical data. Some numerical features in this data set include age, resting blood pressure, cholesterol, max heart rate, and old peak. Some categorical features in this data set include sex, chest pain type, fasting blood sugar, resting ECG, exercise angina, and ST slope. The target variable for this model was heart disease, and it was a binary classification, 1 meaning that the patient has heart disease and 0 meaning that they do not. Moving on to the exploratory data analysis, the EDA, I generated several key visualizations. A histogram shows the target class distribution, a box plot which helped compare blood pressure across outcomes, a correlation heat map which revealed relationships between variables like old peak and max HR. For categorical features, I used a bar chart and count plot to explore class balance and feature interaction. Some key insights from this included that patients with atypical chest pain and lower maximum heart rate have higher disease rates. Old peak and ST slopes were strongly associated with heart disease, so later we should see that as an important variable. Minor class imbalance and the need for encoding categorical features were also identified. I implemented 3 machine learning models, all evaluated using 5-fold cross-validation: logistic regression, k-nearest neighbor, and random forest classifier. A quick performance comparison showed that random forest had the best performance, with around 87% accuracy, 86.5% precision, and around 91% recall. Logistic regression was not far behind this, but slightly worse, and then k-nearest neighbor was noticeably behind both of those. Because random forest performed the best, I decided to tune its hyperparameters. Moving on to optimization and feature importance. Using Grid Search CV, I optimized random forest by adjusting the max depth to 20, the N estimators to 200, and the minimum sample split to 5. After tuning, the final model achieved 89% accuracy on the test set, and this test set used, like we usually do, a 80% training and 20% testing. For model interpretation, I analyzed the confusion matrix and calculated some feature importance. The most important feature was ST_ slope, the second most chest pain type, and third most cholesterol. Looking back at the EDA, it did show a strong correlation between ST slope and chest pain type for heart disease, so it does make sense that these are the most important features. While considering ethics, I defined some important concerns. Bias. Age and sex could introduce biases, as older males were more representative in positive diagnosis of heart disease in this data set. So a misuse of this model would be that it's not 100% accurate, and using it for real medical decisions without professional review could be harmful. Some limitations of this data set include that the assumption for it was that there was accurate data collection and entering into the data set was accurate as possible. And one of the limitations would be that if population demographics or medical standards change, then the model's predictions may become outdated. And by population demographics, I mean such as ethnic background or even from a different country. Thank you.